Welcome to the Deep Dive, the show that extracts the most important insights from your sources. Imagine this. You're on a ward, seeing a patient with these persistent nagging symptoms that just don't seem to fit that quick fix acute inflammation model you've learned about.
Right.
You know, the body's rapid fire alarm response, that immediate fiery thing.
Yeah.
But what happens when the fire just, smolders? When that alarm system stays on day after day, year after year.
It's a really crucial distinction for any aspiring medical professional, honestly.
Yeah.
Acute inflammation is, often seen as that immediate urgency. But chronic inflammation, it's more of this grumbling on process. It can be much more insidious, variable in how it presents, and its long-term consequences are often quite serious.
Exactly. So for you, the aspiring medical professional listening, our deep dive today is all about really getting to grips with this persistent state. We're going to uncover how chronic inflammation arises, what it actually looks like down at the cellular level, it's sometimes pretty troublesome consequences, and how the body forms these specialized, fortresses to deal with invaders it just can't kick out.
And we'll try to use some vivid metaphors, maybe some anchors, to help make these complex ideas stick. This dive is really designed to help you understand, retain, and recall this stuff. We'll focus on how the body attempts to manage an insult. Sometimes it works out okay, but often it leads to lasting issues, like fibrosis or organ malfunction.
Okay, so let's start with a bit of a thought provoker for you listening. If acute inflammation is your body's rapid fire alarm, what do you think fundamentally shifts when that alarm never quite turns off? What makes chronic inflammation so stubborn and, potentially damaging? We'll circle back to that as we go.
Sounds good.
Okay, let's unpack this then. What actually kicks off that persistent grumble of chronic inflammation? Is it always just an acute phase that's gone on too long, or can it start more subtly?
Yeah, that's a critical point. The core difference, the fundamental shift you were just asking about, it really comes down to the persistence of the initial insult and the body's its failed attempt to actually clear it. Chronic inflammation is a host response that, unfortunately, can last a lifetime. It often leaves behind troublesome results, pain, fibrosis, organ malfunction, even gradual destruction, like we see in TB.
So it's not simply a really long acute phase, it's a different kind of battle altogether, like a marathon instead of a sprint.
Exactly, a marathon. And our sources highlighted a pretty useful mnemonic, TFROC, to remember how this sustained state typically begins. Maybe we can walk through that.
Yeah, let's do it. TFROC. So what's the T stand for first?
Okay, the T in TFROC means chronic inflammation, takes over from acute inflammation. This is actually the most common way it happens. The initial injury or infection is just too severe, or it persists too long for the acute response to fix it within days. Clinically, we often draw the line around, say, 6 weeks. If it's longer than that, we start thinking chronic.
Okay, like a minor skirmish that just escalates into a prolonged siege because the first wave couldn't win?
Precisely. Then the A in TFRC, A signifies that it can arise gradually. Sometimes there's no obvious big acute phase. The body's alarm isn't triggered suddenly. It's more of a slow buildup. Think about chronic infections like hepatitis B or C, maybe some autoimmune conditions like rheumatoid arthritis. It just kind of creeps in.
Insidious. Okay, next is F. What's that?
F points to a failure to eliminate the agent. Basically, the body just can't get rid of the problem. Could be really stubborn infectious organisms like Mycobacterium tuberculosis with its waxy coat, or maybe low-level irritants, foreign materials like silica dust perhaps, that the body just can't easily break down or, eat up through phagocytosis.
So the immune system keeps trying, but it's just hitting a wall.
Exactly. It's banging its head against a brick wall, effectively.
Okay, then ROC.
Right. ROC stands for recurrent or continued acute inflammation. Picture situations where acute phases just keep flaring up again and again, like repeated bouts in chronic cholecystitis, often with gallstones, or maybe ongoing bacterial infections where the body never quite clears the initial problem. It's in this constant state of low-grade conflict.
Got it. And finally, the O in TFROC.
O covers other mechanisms. This is a bit of a catch-all, but important. It includes things like autoimmune disorders, where the immune system mistakenly attacks the body's own tissues, think lupus, for example, or maybe chronic biochemical irritants, like advanced glycation end products in diabetes.
Okay, that TFROC framework is actually quite helpful for mapping out the origins.
Yeah, it covers the main scenarios. And just to put this in context with what you already know about host defenses, remember you've got your natural barriers like skin, then the innate immunity, fast, non-specific. using cells like neutrophils and macrophages. And finally, the adaptive immunity, which is specific, it learns, involves lymphocytes, antibodies.
Right, the big players.
Well, in chronic inflammation, we see this crucial shift. The body starts leaning more heavily on those sophisticated innate responses, especially macrophages, and definitely engages the adaptive immune system for the long haul. It's bringing out the specialized troops.
That makes total sense. Adapting the arsenal for a sustained fight. Okay, so let's dive down now to the microscopic level. What does chronic inflammation actually look like through a microscope? You mentioned some clinical signs like pain and swelling might hang around, but the redness and heat often fade.
That's generally true. But the really crucial diagnostic clue when a pathologist looks at the tissue is the predominant cell type they see there. That tells a huge part of the story.
Which brings us back to that question we posed earlier.
Exactly. It raises that important question for you. In acute inflammation, neutrophils rush in like a SWAT team, right? Dealing with the immediate threat. But when the battle drags on for weeks, months, even years, who are the long-haul specialists that step in? And what unique skills do they bring that neutrophils, the short-term responders just don't have?
Great question. So let's meet the crew. We've got another helpful anchor here, the MIL-LPF crew. These are our key cellular players in chronic inflammation. We'll answer that question as we go. First up, M is for macrophages. You call them the masterminds.
Yeah, I think that fits. Macrophages really are the answer to your question about long-haul specialists. They're the big eaters, derived from blood monocytes that circulate for a bit, then move into tissues. And crucially, unlike neutrophils, which live for maybe a day or two, macrophages can survive for months and can even divide right there at the site of inflammation.
Wow, months, so they really stick around.
They do. They usually arrive after the neutrophils have done their initial sweep, and then they kind of take over. They become these central orchestrators. Their main job initially is still phagocytosis, cleaning up debris, dead neutrophils, but also destroying those really difficult-to-kill bacteria like Mycobacterium tuberculosis.
But they do more than just eat, right? You said orchestrators.
Absolutely. Their skills go way beyond just phagocytosis. They're critical for antigen presentation. They process bits of the enemy, the antigens, and show them to the adaptive immune system, specifically T lymphocytes, kicking off that targeted response.
Oh, okay. They're like intelligence officers reporting back to HQ.
Kind of, yeah. And they're also a secretion powerhouse. They pump out all sorts of chemical messengers, cytokines like interleukins and TNF to talk to other cells, growth factors to control cell behavior, things that induce fibrosis, laying down scar tissue, and angiogenesis, which is building new blood vessels, all vital for healing. But sometimes they go too far, causing problems.
Okay, macrophages are key. Next in LLEPF is L for lymphocytes. Sharpshooters. Lymphocytes are the core cells of the adaptive immune system. If you see a lot of them gathered in a tissue where they aren't normally abundant, that's usually a strong sign of an antigenic challenge. The immune system is actively targeting something specific there.
And we're talking both B lymphocytes and T lymphocytes here.
Exactly. You've got your B lymphocytes, which are amazing because they can shuffle their DNA to create this huge library of potential antibodies. When they encounter their specific foreign antigen, usually with some help from T helper cells, they multiply and differentiate into plasma cells. Which brings us neatly to the next letter.
Ah, P for plasma cells, the antibody factories. Precisely. Plasma cells are essentially differentiated B lymphocytes that have become dedicated antibody-producing factories. They churn out huge amounts of specific antibodies tailored to the antigen that triggered their production. Seeing plasma cells under the microscope, that usually implies considerable chronicity. The whole process takes time.
Got it. So back to the T lymphocytes from the L group.
Right, T lymphocytes. They originate in the bone marrow, mature elsewhere like the thymus. Two main types to remember, CD4 plus T helper cells, which are like the field commanders or orchestrators. They guide the T and B cell responses, activate macrophages, really direct the whole adaptive immune show.
Okay, commanders.
And the others. The others are the CD8 plus T cytotoxic cells. Think of them as the assassins. They recognize body cells that are displaying foreign antigens, say, because they're infected with a virus, and they induce apoptosis, programmed cell death, basically telling the infected cell to self-destruct. They do this by punching holes and injecting toxic enzymes.
Wow, pretty dramatic.
It is. And we should also mention natural killer NK cells here, too. They're kind of on the edge of innate and adaptive. They provide a rapid response, especially to viral infections and stress cells like tumor cells. And they don't need that specific antigen presentation that T cells require. They're more like sentinels.
Okay, so MLP covered. What's E in MLPF?
E is for eosinophils. These are the anti-parasite and allergy specialists. They're related to neutrophils but have distinct roles. You see lots of eosinophils in allergic reactions, think atopic asthma, or in response to parasitic infections, like around 6 to some eggs lodged in tissues. They have this very characteristic look under the microscope, usually a bilobe nucleus and bright pink granules in their cytoplasm.
Right, the allergy cells. And finally, rounding out MLPF is F.
F is for fibroblasts and their cousins, myofibroblasts. These are the builders and contractors of tissue repair. Macrophages often recruit them to the site. Fibroblasts lay down the extracellular matrix, stuff like collagen and elastin, forming scar tissue.
And the myofibroblasts.
Myofibroblasts are specialized fibroblasts that also have contractile properties, like smooth muscle cells. They help pull wound edges together, which is good in wound healing, but in chronic inflammation, their contraction can contribute to tissue distortion and dysfunction, part of that problematic fibrosis.
Okay, that MALPF crew gives a great picture of the cellular players. But what about those giant cells you mentioned earlier?
Ah, yes. The giant cells, they deserve a special mention. These are literally giant cells, large and multinucleate, meaning they have multiple nuclei. They form when lots of macrophages fuse together. This usually happens in situations of what we call frustrated phagocytosis.
Frustrated phagocytosis.
Yeah, basically when a particle or an organism is too large or too resistant for a single macrophage to engulf and destroy on its own. So they team up, fuse together to form this massive cell to try and tackle the problem collectively.
Interesting. Are there different types?
There are a few you'll encounter. The Langerhans giant cell is classic for tuberculosis. Its nuclei tend to be arranged around the edge, often in a horseshoe shape. Then there's the foreign body type giant cell, where the nuclei are just scattered randomly throughout the cell. You see these forming around non-antigenic stuff the body can't break down, like a piece of suture material or a thorn fragment.
Okay, Langerhans for TB, foreign body for, well, foreign bodies.
Exactly. And one more, the Teuton giant cell has nuclei in a ring more towards the center, often seen in lesions with high lipid content, like xanthomas. But the key takeaway is that while the general microscopic picture of chronic inflammation can vary, the proportions and types of these MLOPF cells, plus the presence and type of giant cells, give pathologists really crucial clues to diagnose specific conditions.
That makes sense. The cellular fingerprint tells the story. Okay, let's shift gears slightly and talk about the darker side, the troublesome consequences of chronic inflammation. It's a protective response gone wrong sometimes, right?
Absolutely. While the intent is protective, the long-term effects can be really damaging. These are the unwanted effects. We can use another anchor here, FIAA, to help remember the main categories of trouble.
FIA. Okay, what does that stand for?
FIAA helps us categorize these major long-term impacts. It reminds us that the body's own defense mechanisms can, paradoxically, lead to self-destruction or significant dysfunction over time.
All right, let's break down FIAA. Starting with the first F, fibrosis. You called it scar tissue gone rogue.
Yeah, that's a good way to think about it. Fibrosis is the excessive production of fibrous connective tissue, mostly collagen laid down by those fibroblasts we just talked about, often stimulated by cytokines pouring out from macrophages.
But isn't some scarring necessary for healing?
Yes, initially it's helpful. It provides a scaffold for repair, it can help wall off an infection, but the problem arises when fibrosis becomes excessive or happens in the wrong place. It starts to replace the normal functional tissue of an organ, what pathologists call the parental tissue, and that leads directly to organ impairment.
Ah, so it's like paving over a garden. The structure is there, but nothing can grow.
That's a great analogy. And when those myofibroblasts get involved and start contracting, they can physically distort the tissue, worsening the damage. Think about cirrhosis of the liver. You get inflammation, death of liver cells, hepatocytes, massive fibrosis, and then some nodules of regenerating liver cells trying to compensate.
And the causes? Alcohol, Hep B, Hep C.
Right. And visually, under the microscope, or even grossly, you see this dense, often blue-staining fibrous tissue just strangling the normal liver architecture. This leads to portal hypertension, liver failure, even cancer, another example. Chronic cholecystitis, the gallbladder one. Repeated inflammation, often from gallstones. Remember the 4 Fs?
Oh, yeah. Female, fat, fertile, 40. Classic risk factors.
Typically, yes. That repeated inflammation leads to fibrotic thickening of the gallbladder wall, poor function, potential obstruction.
Okay, so fibrosis is a major problem. What's the first I in FIA?
The first I stands for impaired function or organ shutdown. This often follows directly from the tissue damage and that fibrosis we just discussed. A really important example here is chronic inflammatory bowel disease, or IBD.
IBD, right. Crohn's and ulcerative colitis.
Exactly. It's persistent inflammation of the bowel, but we still don't fully understand why it happens. It's idiopathic. In Crohn's disease, you can get inflammation anywhere in the GI tract, from mouth to anus. It characteristically causes skip lesions, meaning patches of inflamed bowel separated by normal areas, and the inflammation goes through the full thickness of the bowel wall. It's transmural.
And that transmural inflammation can cause problems like blockages, right? Strictures.
Exactly. Strictures leading to obstruction, and also fistulas, which are abnormal connections between loops of bowel or between bowel and other organs. Now, ulcerative colitis, you see, is different. It primarily affects the large bowel, usually starting in the rectum and spreading upwards continuously. The inflammation is generally confined to the mucosa, the inner lining, not full thickness.
And UC doesn't usually have granulomas, but there's a cancer risk.
Correct. No granulomas is a key distinguishing feature pathologically, and yes, there's a significant risk of developing colorectal cancer, especially with long-standing extensive UC. Now, usually chronic inflammation causes loss of function, but rarely it can cause increased function.
Increased function. How?
Think about Graves' disease. It's an autoimmune condition affecting the thyroid. The body makes autoantibodies that actually mimic thyroid-stimulating hormone, TSH. These antibodies bind to the TSH receptor on thyroid cells and stimulate them constantly, leading to overproduction of thyroid hormones T3 and T4 and symptoms of hyperthyroidism. So the inflammation, or rather the immune attack, increases organ function.
Huh. Interesting twist. Okay, so we've had F for fibrosis, I for impaired function. What are the two A's in FIA?
Right. The second A is for atrophy. We sort of touched on this under impaired function, but it's worth highlighting. Chronic inflammation can lead to the progressive loss of glandular tissue, for example. Think autoimmune gastritis destroying stomach lining cells, or chronic pancreatitis leading to loss of pancreatic tissue.
Okay, atrophy. And the final A?
The final A stands for inappropriate immune response. This really gets to the heart of autoimmune and allergic diseases. Here, the immune system, with inflammation as its primary weapon, essentially misfires. It goes wrong.
Self-attack or overreaction?
Exactly. In autoimmune diseases, the immune system attacks the body's own normal tissues. Rheumatoid arthritis, RA, is a classic example. It's an autoimmune disease, often involving rheumatoid factor antibodies. It typically hammers the small joints, causing inflammation, cartilage, and bone destruction. But it can also have systemic effects affecting lungs, skin, spleen.
And the other type of inappropriate response?
Atopic diseases. This is where the immune system overreacts to generally harmless substances in the environment, allergens. Think asthma triggered by pollen, hay fever, eczema, food allergies, even severe anaphylaxis. This usually involves IgE antibodies, mast cell degranulation, histamine release, that's type 1 hypersensitivity.
Okay, so FIAA gives us fibrosis, impaired function, atrophy, and inappropriate immune response. A pretty grim list of consequences.
It highlights how a process designed to protect us can go seriously awry when it becomes chronic and uncontrolled.
So let's think about a specific scenario. If the body's facing an invader, maybe something like TB, that it just can't clear easily by sending in macrophages to eat it, what extreme measure does it sometimes take? How does it try to wall off the problem?
Now you're leading us towards a really specialized form of chronic inflammation, granulomatous inflammation.
Right, and the hallmark is the granuloma itself.
Exactly. Granulomatous inflammation is defined by the presence of granulomas. So to answer your question about the extreme measure, the granuloma is that measure. It's the body building a specialized fortress or a containment unit.
A fortress built of cells.
Pretty much. A granuloma is an organized, tightly packed collection of specific immune cells, primarily epithelioid cells. Now, these epithelioid cells are actually modified, activated macrophages. They change shape, become elongated. Their nuclei look kind of slipper-shaped or banana-like under the microscope, and they pack together really tightly.
Okay, so activated macrophages forming a wall. What else is in there?
A granuloma might also contain some of those giant cells we talked about, especially Langhans type in immune granulomas. There are usually lymphocytes, particularly T cells, often forming a rim around the central collection of epithelioid cells. And sometimes, particularly in infections like TB, there's central necrosis, dead tissue.
So the whole structure is designed to wall off the threat, right? Concentrate the immune cells right there to try and kill whatever's inside.
Yeah. That's the idea. It's a strategy for dealing with things that are poorly soluble or difficult to eliminate, like certain bacteria, fungi, or foreign materials. It walls off the threat while focusing the immune attack. It's crucial when standard phagocytosis by individual macrophages just isn't cutting it.
Are there different kinds of granulomas, like the giant cells?
Broadly, yes. We distinguish between foreign body granulomas and immune granulomas. Foreign body ones form around stuff that isn't necessarily antigenic but is poorly soluble. Think suture material, talc powder, maybe a splinter fragment. They tend to have lots of macrophages, foreign body type giant cells, maybe some epithelioid cells, but usually fewer lymphocytes.
Okay, makes sense. And immune granulomas.
Immune granulomas, sometimes called hypersensitivity granulomas, are different. They result from a persistent T-cell mediated immune response to antigens that are hard to get rid of. Classic causes are infections like Mycobacterium tuberculosis, certain fungi, maybe syphilis. These granulomas typically have prominent epithelioid cells, often Langerhans giant cells, lots of surrounding lymphocytes, and crucially, they can have that central caseating necrosis.
Caseating, meaning cheesy.
Exactly. It looks like crumbly white cheese macroscopically. That caseous necrosis is very characteristic of TB granulomas.
So what are the main triggers for granulomatous inflammation overall?
Key causes to remember. 1, that mildly irritant foreign arterial sutures, bits from artificial joints. 2, infections, especially mycobacteria, TB leprosy, some fungi, syphilis, cat scratch disease, leishmaniasis. And 3, some important diseases where the cause is still unknown, like sarcoidosis, which typically forms non-caseating granulomas in lymph nodes and lungs, and also Crohn's disease, which can have granulomas unlike UC.
Okay, Crohn's can have them. Good distinction. And tuberculosis seems like the absolute classic example for granulomas.
It really is, caused by mycobacteria, mostly M. tuberculosis. These bacteria are tough customers mainly because of their thick, waxy cell wall, rich in mycolic acids. It helps them resist being killed inside macrophages. They don't produce powerful toxins. They cause disease mostly by just persisting and provoking this intense cell-mediated immune response, leading to tissue damage.
And how does it typically start breathing it in?
Usually, yes. Entry via the respiratory tract often leads to what's called a Gone complex. That's the initial small lesion in the lung, often subpleural, plus involvement of the nearby draining lymph nodes. From there, it can be arrested, walled off, becoming latent TB, or it can progress to active disease or reactivate later in life.
And it can spread.
Oh, yes. It can erode into a bronchus, spreading within the lungs, causing tuberculous bronchial pneumonia, or it can get into the bloodstream hematogenous spread, leading to tiny granulomas seeding throughout the body, called miliary tuberculosis. This causes systemic symptoms like fever, malaise, weight loss, that consumption picture.
And the pathological hallmark we look for.
The hallmark is the caseating granuloma, that organized structure of epithelioid cells, often with Langerhans giant cells, a rim of lymphocytes, and that central cheesy necrosis. If you do a special stain, like Ziehl-Neelsen, you can often see the acid-fast bacilli, AFB, within the lesion.
Got it. Caseating granuloma screams TB. Now, you mentioned a crucial distinction earlier, something that often confuses students.
Ah, yes. Very important. Granulation tissue is not the same as a granuloma. Please remember this.
Okay, emphasize that. Granulation tissue versus granuloma.
Right. Granulation tissue is the pink, fleshy, bumpy stuff you see in a healing wound. Microscopically, it's basically new, leaky capillaries and proliferating fibroblasts, plus some inflammatory cells mixed in. It's a general, non-specific healing response, laying down a scaffold for repair.
Okay, healing scaffold.
Whereas a granuloma, as we've just spent time discussing, is a highly specific, organized collection of immune cells, primarily epithelioid macrophages, formed to contain a persistent, difficult-to-eliminate threat. They look completely different under the microscope and represent fundamentally different processes.
Excellent clarification. Granulation tissue, healing. Granuloma, Key's containment fortress.
Couldn't have said it better myself.
So, wrapping our heads around all these complex mechanisms, the cells, the mediators, the outcomes like fibrosis or granulomas, it's obviously absolutely critical for figuring out how to manage chronic inflammation, right?
Absolutely. While we aren't diving deep into pharmacology today, it's definitely worth highlighting how different therapies specifically target the pathways we've been talking about. It connects the basic science directly to clinical practice.
Yeah, like how do these principles translate into treatments?
Well, we can think about different levels of intervention. For fairly general anti-inflammatory effects, reducing pain and swelling, you might use something like ibuprofen. It's a non-selective COX inhibitor, so it reduces prostaglandin synthesis. Useful in some acute on chronic situations, maybe.
Okay, basic NSAID. What about stronger stuff?
Then you've got corticosteroids like prednisolone. These are much broader and more potent. They hit inflammation from multiple angles, inhibiting synthesis of prostaglandins and leukotrienes, suppressing pro-inflammatory genes, stabilizing lysosomes. At higher doses, they're also significantly immunosuppressive.
Right, the big guns, but with side effects.
Definitely. Then you have drugs that target cell proliferation, like methotrexate. It's technically a folate analog, messing with nucleotide synthesis, so it slows down the division of rapidly proliferating cells, including those inflammatory lymphocytes. That's why it's a cornerstone in treating rheumatoid arthritis.
Okay, slowing down the immune army. And what about really targeted therapies?
That's where the biologics come in, especially monoclonal antibodies. Think about adalimumab. Remember that HapMab ending tells you it's a monoclonal antibody. Adalimumab specifically targets and neutralizes TNF-alpha.
TNF-alpha, one of those key cytokines secreted by macrophages we mentioned.
Exactly. TNF-alpha is a major driver of inflammation in conditions like RA, IBD, psoriasis. So blocking it with a drug like adalimumab can be incredibly effective. These targeted therapies really show how understanding the specific molecular players allows for much more precise interventions.
It really drives home why knowing this underlying pathology is so essential, not just for exams, but for actually choosing the right treatment for a patient.
Precisely. Recognizing which pathways are most active in a particular patient's disease helps tailor the therapy.
Wow, okay. That was quite the deep dive. We've really covered a lot of ground on chronic inflammation, from its insidious onset, that persistent nature, often stemming from the body just failing to clear an insult,
To the specialized cells it calls upon, that whole MLPF crew and the giant cells.
and its often devastating consequences, the FIAA framework:
Yeah.
fibrosis, impaired function, atrophy, inappropriate immune responses.
And finishing with that unique cellular architecture, the granuloma, the body's fortress.
Yeah, it's clear that chronic inflammation is way more than just acute inflammation dragged out over time. It's a really complex, dynamic, and often prolonged struggle between the host and whatever it's fighting.
It absolutely is a very different beast.
So as you, our listeners, move forward in your medical training, hopefully you can see how recognizing the subtle, persistent grumbling of chronic inflammation is going to be just as critical as spotting that acute fire alarm. Looking at the mix of cells, the type of fibrosis, whether giant cells or granulomas are present, these are all vital clues.
They're clues that help you identify the specific disease process and, ultimately, guide how you manage that patient. It really makes you appreciate the incredible complexity unfolding at the microscopic level all the time.
It does. The body's attempts to protect itself can lead down such complicated and sometimes destructive paths.
Indeed.
So maybe let's leave you with this final thought to mull over. If chronic inflammation represents the body's prolonged, sometimes desperate attempt to manage an insult it just cannot fully eliminate, what does this tell us about that very fine line between defense and self-destruction in our own physiology? And perhaps, how might future medical breakthroughs find better ways to tip that balance back towards healing, towards resolution, but without completely shutting down the necessary immune responses we need to survive?
That's the million-dollar question, isn't it? A powerful thought to reflect on, especially as you prepare to care for patients who live with these challenging chronic conditions every day.
Absolutely. Well, thank you for joining us on The Deep Dive. We genuinely hope this exploration helps you master the complexities of chronic inflammation.
We hope so too. Keep studying.
We'll catch you next time.